All right, good evening. It's a real pleasure to take this standpoint. Now, who do you trust? Beautiful Laura Waters or myself? That's an easy question. She has how many followers on Twitter? 10,000. I have 300, and half of them are porn stars. So, what does that mean? That means she is a trusted intellectual dominating media, and she has all the support. But then what does Dr. Waters think of 2DR therapy? Recent findings, randomized trials support the use of dolutegravir-based 2DR, both for initial therapy and suppressed switch. And just remember, what does Wikipedia say about majority? More than 50%. So we could finish the debate already here. But I agree with her. She's absolutely right. She knows the literature. So what have the registrational trials shown? In Gemini, there's non-inferiority over 3 years. All looks great. You know the data. And considering that there was some differences in the inclusion criteria than some other trials, so people above 500,000 were not included, there have been subsequent analysis looking at different kind of viral load strata and CD4 counts, all showing non-inferiority. It has entered the guidelines. And then there have been subsequent studies looking actually at real-life populations with higher viral loads, and look at that. Viral load above 500,000, and still the majority of patients respond. There seems to be no signal. So I think we're doing pretty well, even in other data cohorts. And then there's always this issue about resistance. It was already mentioned that there is no resistance. We remember that one of the hallmarks of modern antiviral therapy, why we choose and prioritize and emphasize the use of second-generation integrase inhibitors, that they're doing so well, and there is no resistance, and that is true for 2DR, just as well as for 3DR, and this is from that rapid start initiation study showing that. And one of the only issues we have is that what about people who have hepatitis B? We want to give tenofovir-based therapy for those, and I absolutely agree, but remember, majority is over 50%, and how many people have hepatitis B? Not 50%, not even in this room. So, and if you look at resistance associated with hepatitis B, that didn't occur in the trial because for those who treat a lot of hepatitis B patients, that takes quite a while to develop under a 3TC monotherapy or a 3TC-based therapy in the setting of combination. I just put this in to remember us all that we're living in 2022, so the amount of people who have chronic hepatitis B is actually getting smaller and smaller because of birth vaccination, and gratefully that is so. So one of the very few WHO hepatitis elimination goals are probably going to be achieved by introduction of HPV vaccination, because that's the only goal which seems achievable at this point. There's going to be a lot of hampering on what about pre-existing mutations? Is that going to play a role? And should we all worry? Should we constantly have a phone line with Jonathan Shapiro? No, because in the archive mutations, if you find them or you don't find them, you look for them or you don't, it all seems to work very well. So there is a lack of effect of a prior M148V on treatment outcomes. So that is kind of reassuring. And then really, is TAF that safe? So because most of the 3 drug regimens will be based on a TAF-based regimen. But just see, there are increasing reports of nephrotoxicity, even with TAF. And there's actually a whole literature review of all these different case reports. And look who is highlighting that and showing that at a recent virology education meeting. It is Professor Waters herself. What can you say? And then let's not forget, I'm not going to go into the whole weight issue. I only have 7 minutes. I don't want to go over that. So, but what we have to appreciate is that there is this discussion. You remember that in advance, people who had TAF versus TDF in combination with dolutegravir did a little bit more unfavorable on the weight side. And we have a special interest in liver disease, so we're also looking at the formation of hepatic steatosis by CAP measurements. And what do we see over extended treatment periods? There's a signal for TAF, contributing to more weight gain and also contributing to more emergence of hepatic steatosis. Remember, in the US, where people enjoy, in particular, big bottles of soft drinks and fast food, which is not the topic of my debate, but easily could be, you will see that in that setting, there is a high rate of NASH formation. That has become the leading cause of liver transplantation. NASH is more prevalent in HIV patients, so there is concern. What is this weight gain issue all going to lead to? So if we can leave something away, why are we not going to do that? For what reason are we going to give a third drug which may cause toxicity and we really don't need, which is what I showed you from the efficacy and resistance point. Now also, we're living in an environment we shouldn't forget. We're talking about climate changes, we're talking about wars, we're talking about migration, and all we're hearing is, in the winter, we're all going to sleep outside because there's neither energy nor money to pay the rent of the place we're living in. So money is becoming more important, everything is cost sensitive, and you see that actually, at least in my country, prescribing a 2DR regimen will be cost sensitive, and we can save actually money. We can contribute to society and make a change. So why do we have to waste money on drugs we don't really need? Did you ever ask that yourself? I think we have to start being a little bit more cost sensitive here. And Dan is looking like, what? I've never been cost sensitive.
No, I just can't quite figure out the numbers.
That's the purpose of the slide. He's a mastermind. He found it immediately. You know, that's the weak spot. All right. And then, but now, you will say, wow, why is this guy concentrating predominantly on a 3DC delivery? I mean, there are other 2DR regimens, and you're absolutely right. And one of the big quests of community was, we want to have different modes of delivery. If you do a questionnaire between people living with HIV, you will find that there's a lot of people who are sick of tablets, who feel stigmatized, don't want to take them. So actually having options, giving other forms of delivery, which we have available as a 2DR regimen, is also an asset which belongs to this particular drug regimen, and clearly has given us a lot of new options in our armamentarium. And what about the body language? Look at that. Laura has this 2-duck necklace, remember? And she said, I have a 3-duck necklace. I removed it because I really like 2-drug therapy. And then, look at that. She's showing me the fingers. 2, she said 2 are better than 3. There you go, Laura Waters. So, in summary, 2DR is equally efficacious. There's no resistance development in first-line or switch therapy. That's what Dr. Waters says. And who's going to say something against her? Otherwise, you're going to be killed on Twitter or Instagram and fried on that beautiful Hitchin barbecue. And who wants to land there? Less drugs promise less short and long-term toxicity. TAF-containing 3DR therapies associated with more weight gain and other forms of toxicity. I showed you all these case reports. Cost savings possible with less drugs. Pill sizes become smaller, so even if size matters, not in this context. And 2DR therapy is also available with different modes of delivery. So, thank you very much. 2DR is the ideal antiretroviral treatment, opts for the majority of people living with HIV. And I still have 43 seconds left. No, I don't.